Good afternoon. If you're here for the Medical Cannabis Working Group Committee, you're welcome to come on and have a seat. Members of the committee, glad to have you here for our very first meeting, first hearing. First thing we need to do is adopt rules, since this is a brand new committee. If you'll look in your packet, there are rules for this committee, and so I'm going to give you just a second to peruse them. They're pretty standard. Pretty standard with the and consistent with what other rules are for other committees of this nature. So, if you will, just take a second to look at them, and then after you've had a chance to look at them, if it's the will of the committee, I'll need somebody to move that we adopt these rules too. So. Okay, we have a move. Is there a second? Okay. All those in favor of the rules that are in your package being the working rules for our committee, say aye. Aye. Any opposed? Okay, we have rules. So we are now an official committee, which is good to know. Okay, let me just, for the committee members' information, let me walk you through kind of what our game plan is today. We have several folks that have other committees and will be coming in. I know Micah Gravely is presenting a bill, a very important bill, a firefighter bill in a committee. Terry England is tied up with some budget obligations and will be here shortly. And I believe Miss Katie Dempsey will be here at some point too. So we should have our full committee here at some point. Here's what we are going to do. This special committee that the Speaker has created specifically to deal with the medical cannabis issue in our state, we will be hearing the two bills that have been introduced in the House that deal with medical cannabis, HB 65 and HR 36. And today, specifically, we will be having discussion about HB 65. We will not be having discussion or hearing or testimony about HR 36. Now, let me just walk through the committee just real briefly what the two bills are. HB 65 does four things. It adds 6 conditions to the current law that's in place right now: Tourette syndrome, autism, intractable pain, PTSD, Alzheimer's, and AIDS. The second thing it does, it removes the end-stage qualification from the 5 current conditions that are included in current law: cancer, ALS, MS, Parkinson's, and sickle cell. Third thing it does, it removes the 1-year residency requirement. And the fourth thing, it removes the quarterly reporting requirement for physicians. And so that's what HB 65 does. We'll have some discussion about that bill here in a moment, and we're going to take some liberty. It's not going to be a typical standard bill presentation where I'm going to sit down there and you guys are going to answer questions. We're just going to have some discussion about the bill and questions that you may have just kind of informally. Then we will have a couple of presentations. One by Donna Moore from the Vital Records, who will give an assessment of the low THC oral registry, what's been going on with that at this point. And then a presentation from Dr. David Bradford and Ashley Bradford, professors at the University of Georgia, who have done some study on opioid usage and the effect of medical cannabis legislation on opioid usage in states. And then we're going to open up for testimony for folks who are here and who wish to speak. Let me just lay a couple of ground rules for you. I think we got a handful of folks that have signed up so far. To folks who are here who want to testify today, we are going to have and would like to hear testimony from anyone that would like to speak. But specifically, we will be addressing today HB 65, which is the bill that contemplates adding conditions to current law, and we will not be having discussion or testimony. If you're here today and you want to talk about in-state cultivation or why we need to grow it here in our state or what's the best model for that, that's not the testimony for today. And if you start going down that path, I'm going to cut you off, because that's not why we're here today. I promise you we will have discussion about that, because we're going to debate H.R. 36, the constitutional amendment, at a later time. And so if you've signed up and all you want to do is talk about here, I can tell you how to grow marijuana and set up the right infrastructure in our state, that I would ask that you not testify today, because we've got a lot of folks here, and we want to make sure everyone who wants to talk about the conditions or their personal experience of why a condition should be added or not be added gets to testify. So that's the ground rules for today. And depending on how many people we have sign up, we'll limit the amount of time for testimony as well too. And then after we have all that testimony, we will then, depending on what the will of the committee is, we may take action on HB 65 today. So that's our agenda and game plan. Everybody good with that? So that's kind of where we are. Let me ask, if you will, let's talk about HB 65 for just a minute. And you should have a copy of the bill in front of you. We're working off of LC 297227, and I want to just make sure the committee understands the rationale behind the 4 changes to current law. Let me just remind everybody, current law now allows legal possession of medical cannabis oil for 8 medical conditions. And the medical cannabis oil can only have a maximum THC level of 5%. We're looking at adding 6 conditions to that current law: Tourette's, autism, intractable pain, PTSD, Alzheimer's, and AIDS. We are looking at adding those 6 conditions because all of those are consistent with what has been done in other states that have medical cannabis legislation. Currently, there are 28 states that have full-blown medical marijuana legislation in which there's no THC limit and a multitude of diagnoses allowed. There are 14 states that have low THC oil legislation similar to what we have here in Georgia. And so there are 42 of 50 states that have some type of medical cannabis legislation. And so we heard testimony for the last 2 years about citizens who wanted to add conditions. We also looked at what other states were doing. So that's the rationale behind adding the 6 conditions to the existing law. The second thing, we're removing the end-stage qualification under current law for cancer, ALS, MS, Parkinson's, and sickle cell. And you'll hear some testimony today probably from some folks of why we need to remove that severe or end-stage qualifier from the existing conditions. The third thing, we're removing the 1-year residency requirement, and that's, again, a request from citizens. For instance, we've had some military personnel who have moved our state with a disabled child who would potentially benefit from medical cannabis oil, who were restricted from being able to immediately take availability of our law because they had not met the 1-year requirement. And so that's the rationale for removing that. And finally, there's a quarterly reporting requirement for all doctors who sign up someone for the registry. And we specifically have received correspondence from physicians asking us to eliminate this extreme burden that these physicians are facing to provide quarterly reporting that they're not required to do on any other medical condition that they ever diagnose. And I want to read 2 letters from you real quickly. One is from Dr. Philip Holt, who is the assistant professor of pediatrics and neurology at Emory University, one of the foremost pediatric neurologists in the state. And I think we have a copy in the packages. You should have that. Where basically his last paragraph is where he's basically begging us to eliminate the quarterly reporting because of the burden it's put on him as a physician. And so, and then we also have another letter from Dr. Robert Flamini, who is a neurologist here in town in Atlanta, who is, again, one of the foremost physicians with pediatric neurologists, who again is begging us to eliminate this quarterly reporting. And so we're doing this in response to doctors who are working with these patients, and so that's the rationale for the quarterly reporting. So here's what we're going to do. We're going. If you have any questions about the particular bill, I'll entertain those right now. We'll talk about them very briefly, and then we'll get into the kind of testimony. And so we'll open it to the committee if there are any questions regarding the bill at this time. Representative Beverly. Yeah, good job. Yeah, approaching 18. Why don't you just speak loud? Sorry, JB, or either you want to try 17 or 19? Try 19. There you go. No, that's not working either. We're doing something.
Left side of the table. All right, everybody be real quiet.
Yeah, there you go.
So I just have thanks, Mr. Chairman, for doing this, and this is a great bill. I have a question about the 1-year residency requirement. Is it just because of military families? Because I think I have somewhat of a concern if somebody moves in, gets the oil, then leaves. And I don't necessarily know that's a good thing for Georgians and public safety, for that matter. And if it's just about the military, should we not stipulate that in the bill? Or is there some other group of people that maybe would be affected by this? If it's military, maybe we just grandfather them in and then leave it as is, or was there another group?
Fair question, and the answer is no, it's not just for the military. We know of specific other instances where families have moved. Take, for instance, a family lives out of state. They have a special needs child. They make the determination that maybe they need to go live with mom and dad, with the grandparents to help with they need more of a support network, and so maybe they move to Georgia for that particular reason. We know of one particular situation that I know of that came up, and so they were, even though they were moving to Georgia so they could be near their support network with their special needs child, they were precluded from being able to be legally possess the oil. So it's not just military at this point. And the reality is, Dr. Beverly, is what we found out is that people aren't moving into the state to get medical cannabis oil. They're having to leave the state and to go get it. And so I don't think the rationale when the Senate put this in 2 years ago was they were concerned that all of a sudden we would have people who would be a potential burden on the financial system here in Georgia because maybe they were on Medicaid or Medicare, and the reality is, people aren't moving into our state so they can access medical cannabis oil. They're only moving in because maybe they need to be with their support network, or maybe because the military is required. I'm open to suggestions on that, but I don't think it's the potential public health issue that you mentioned. But I'm open to suggestions.
Just a quick.
Yeah, sure. Mm-hmm.
So as soon as we get the language for HR, the House resolution done, then we start to produce it in the state of Georgia. Maybe the secondary effect is now people start coming in. Of course, they can't do it now because we're not producing it. But once that happens, the secondary byproduct is, okay, now we got a glut of people coming in the state of Georgia who may have awkward ways of doing things, right?
Right.
Maybe we address that after the fact.
I think that's probably the best course of action is to deal with that at that time. You're right, and because when and if we do production in the state, then we're kind of looking at a whole different ballgame anyway. So, any other questions? Okay, we'll move forward with our testimony, and first up we've got Ms. Donna Moore, who is Executive Director for the Vital Records Agency of the Department of Public Health, and she's going to give us a quick rundown on the low THC oil registry and where we are so far since the law has been in place for 2 years. So, Ms. Moore, the floor is yours.
Thank you, Mr. Chair. Can you hear me okay? Microphone on?
We do
there
now.
We go.
There we go. Yep.
All right, I'll pull it back a little bit. Is
Yep.
this okay?
No, we're good. Yeah.
All right. Mr. Chair, members of the working group, thank you. It is a pleasure to be here with you today. I bring greetings from Department of Public Health and Commissioner Brenda Fitzgerald, to whom Vital Records and my organization reports. I'm talking to you today about the last 2 years and the journey that we've taken in implementing the HB1 bill from 2 years ago, and the experiences we've had with patients, physicians, and caregivers. These statistics are from our registry through January 26, last week. We right now have 294 physicians who are active in our registry. We've had 318 physicians attempt to register, and the delta between those are that we've had 24 registrations denied by the Composite Medical Board. And that could be because a physician's license isn't current, the physician doesn't practice in Georgia, the physician's not a physician. We did have, yes, that has happened. The alleged physician is a 17-year-old boy. But we have a very close working relationship with CMB, and we ping their database to make sure that the physicians who are registering and entering the registry are indeed physicians. We have had a little more than 1,300 patients registered since we started the registry and stood it up in July of 2015. We now have a little more than 1,200 who are active in the registry. We've had 4 patients in the registry pass away, and we have about 140 patients who are no longer under their physician's care. And I'll talk about reasons why in a few minutes. So we have physicians, we have patients, and then we have caregivers for those patients. And we have a little more than 1,600 caregivers who have registered for low THC oil cards. A little less than 1,300 are now active. We've had 209 cards canceled, either because the patients are no longer under the care of their physicians, they have passed away, they have voluntarily asked us to cancel their cards, and we have 139 cards waiting to be picked up. I also want to share with you here on this graphic the percentage of patients by condition. You'll see that almost 70%, if you read the pie chart from the top of the pie chart or clockwise, almost 50% of our patients are seizure related. We have about 22% that are cancer, and those two categories make up the bulk of our registry. So almost 70% are seizures or cancer, 11% is multiple sclerosis, 9% at Crohn's, mitochondrial disease is 4%, Parkinson's 4%, sickle cell 2%, and then you see it's fallen off my legend, but the numbers there, 2% is also ALS. There are about 24 patients that are registered with more than one condition in the registry. I also want to share with you the patients by age group. Again, reading clockwise, 34% are greater than 50 years of age, so almost a third. Then 32% are between the years of 25 and 49, 24% are youth, and then 10% are between the ages of 18 and 24. And then if we look at THC patients by race, about 2/3 are Caucasian, the next largest group is Black or African American, and then we have 14% that weren't registered by race and 1% Asian. And then what have our learnings been through our journey? The Department of Health was asked to stand up the registry and to design the registration process, the fulfillment of cards, and the distribution of cards, and that came to Vital Records. Why? Because Vital Records does just that. That's our core competency. We issue certificates. Issuing cards is not very far from issuing certificates. We maintain confidential information, which this is as well. So the commissioner asked us to implement this program. So part of our learnings through this journey is that it was dependent in the beginning and design and throughout fulfillment to have a tight coordination with the Composite Medical Board. State Office of Vital Records doesn't tell anyone that they can't register. We don't tell anyone that they can't be in the registry. The Composite Medical Board avails their database to us. We ping that database to see if they're a licensed physician. So that coordination and that partnership has been paramount. We have noticed that when physicians leave the state, their patients and their caregivers are without a physician. We have physicians, as Representative Peake mentioned, not wanting to complete reports on their patients on a quarterly basis. I've done it myself. It takes about 10 minutes per patient, but a lot of our physicians have more than one patient. So you multiply that 10 minutes by however long it takes to fill out or however many patients you have in the registry. It's a time burden. We also have physicians' assistants, PAs wanting access to the registry. So that's an important distinction as well. Right now, only physicians can enter the registry and register patients. We have patients that will call us and ask for physician referrals. And we don't fulfill that purpose. We don't fulfill those requests. We encourage them to seek out a physician who can establish a rapport with them and a relationship with them. Because remember, physicians are not prescribing into the registry. They are just reporting and recording that they know that their patient is using cannabis oil. So we always encourage patients to find the best physician for them, not a physician who is in the registry. We have patients and caregivers who are unable to pick up cards. We have 18 distribution points in our boards of health and My Vital Records offices across the state of Georgia. And if a physician or a caregiver cannot pick up a card, one of those 18 distribution points or even members of my staff will take the card to the caregiver. We have had patients who are inside the registry getting benefits from their use of low THC oil call my office and say, would you please cancel my card? Because my employer has told me that if I fail my drug test, I'll lose my job. And Ms. Moore, would you please write me a letter on your official stationery with your signature and give it to me telling so I can hand it to my employer that you have canceled me out of the registry. And we've had to do that on a handful of occasions. We've had instances when the physicians who enter the information into the registry, the information was not correct and we weren't able to locate the patients or the caregivers. And so we've had to go back to the patients, the physicians on a manner of occasions to try and get that information corrected so we can notify patients that their cards are ready. We have had vendor inquiries and folks wanting to buy the list of physicians and patients and caregivers in the registry. We have not done that either. But those requests are out there and we just very politely turn them down. As I mentioned, our first card was issued in July of 2015. All of our cards are issued with a 2-year expiry date. So we're getting ready to have that first batch of patients and physicians expire. So we have to think about how do we reissue those cards for patients that still need them. And then it's also important for me as the registrar to consider what it means operationally as I run this program, as my team runs this program, to expand from the original 8 conditions. If we add 6 more conditions, what does that do to the workflow? What does that do to our expectation of ourselves that we are able to turn around these cards within 2 weeks to caregivers or patients? So that is something that's on my mind as well. And that is my presentation. Any questions?
Thank you, Ms. Moore. There may be several questions. Any from the committee? I'll start if there are none. To your first point on the first page that you've denied applications to folks who have applied as physicians under the registry, would you take away from that that this is working? I mean, we are keeping the bad actors out who maybe we've been able to monitor that and keep folks who are not who shouldn't be registering patients out of the system.
I concur.
Yeah.
I agree. Because if we were, again, if we did not have the CMB's database of physicians, we wouldn't be able to do that. And the fact that we've been able to find 24 and we've been able to validate by license number who is in the registry, I think we have indeed cleared out the bad actors.
Okay. And then the second question I would ask is, the concern you have about expanding the program from adding conditions, do you have, I mean, let's assume we're at, what, 1,300 patients now, and we add conditions, and let's say we were to go to 3,000 or 4,000. Do you have the capacity to do that, or is that a budgetary issue that we're going to be looking at?
I do not have the capacity to do that. I have 4 FTEs, 4 employees who are dedicated to this program. Mm-hmm. And we have been successful at that service level agreement of getting the cards out within 2 weeks of receiving the order. We could stretch that out 3 to 4 weeks and just have a longer queue with that staff. But I would think that would be, I don't think that would meet the needs of the individuals who are requesting the cards. Right. I don't think I need to double my staff, but I do think we need to think long and hard about what are the incremental resources that we need in order to staff this program if we add the 6 new conditions.
Well, Chairman Terry England's on this committee. He will be here shortly, so we'll make sure we have that conversation with him as well too. So
okay,
the Appropriations Chairman, yeah. Yeah, of course, let's see. 23 is Representative Beskin.
Thank you, Mr. Chairman.
Sorry, we are having difficulty.
On and off a couple times.
Try it again. Try it again.
Can you hear me now? Turn off in the back. I will just speak up.
Yeah.
Turn off in the back. Can't hear me. Whatever.
Try in the back, Representative Beskin. Try that right there. See if that helps any. Yeah, we're just gonna have to go with what we got. So.
Okay. What types of information do you have with the registry? Do you have the information of the patients and the condition for which they are accessing the oil?
Yes, ma'am.
The reports that the boards have been, that the physicians have been filing with the board, you're not the board, are you? So you've not been the repository of those physician reports, is that right?
That is correct.
Okay, so with the registry, you would know how many patients are registered and the conditions for which they're registered.
That is correct.
Okay, thank you.
Any other questions, members of the committee? Ms. Moore, I've had opportunity to chat with a lot of the citizens that have gotten registered, and with only maybe 1 or 2 exceptions, they have spoken glowingly of the process. And so I want to give you a real shout out that you guys have done a great job. And in the couple of instances where there were issues, y'all responded very quickly. And so, and this is an important issue. You know, these are families that are hurting and suffering, and citizens are suffering. And so the quicker we can respond, the better. So thank you, and good job. Keep up the good work. Thank you for being here today.
Thank you.
Yeah, thank you. Okay, we're going to next have Dr. David Bradford and Ashley Bradford. Ms. Bradford, I don't think you're a doctor. Are you? Okay, okay. Not yet. Okay, so we just want to. Okay.
If you wanted to award it, well.
Yeah, save you some money, wouldn't it?
Yeah, that's
because I believe it's a father-daughter team. If
that's right, we could avoid some tuition payments.
While you're getting that set up, let me introduce Dr. Bradford. I had a chance to meet Dr. Bradford over lunch at a fine establishment in Athens several months ago, and it was interesting, the study that they have done of an analysis of opioid usage and cost of the opioid epidemic in our state, and the correlation in states that have medical cannabis legislation. And so I thought it might be really appropriate. You know, Governor Deal has said that the opioid addiction is something he wants to deal with in our state. And there is direct correlation in states that have medical cannabis legislation with reduction in opioid abuse, opioid deaths, and opioid cost as well. So I thought it would be appropriate for this committee to hear this peer-reviewed study that has been done by one of our finest in our state. So Dr. Bradford and Ms. Bradford, we turn it over to you.
Thank you very much to the committee for the invitation to talk to you today about our research looking at the impact of medical cannabis laws across the country and their relationship to prescription drug use and indeed, as we'll mention at the end, opiate deaths and what implications that might have for Georgia. We're going to quickly go through this presentation because I understand that you may want to ask us questions at the end. My daughter and co-author, Ashley, is a Master of Public Administration student at the University of Georgia, and I am in the Department of Public Administration and Policy. We're both in the same department temporarily, which is nice. We're going to quickly also overview some very recent developments in the academic world that bear on the future scheduling of marijuana, and cannabis, I should say, for medical purposes, which might be of interest and important for you as you consider how you're going to modify the laws of Georgia. So at that, I'm actually going to turn it over to Ashley, who's going to walk through a bit of the quick overview of the policy background and the developments from about 3 weeks ago from the National Academies of Sciences. And then I will quickly go over a broad overview of our findings and then entertain your questions.
And I believe we have that PowerPoint in your package as well too, to the members of the committee. Okay. Ms. Bradford?
I'm very excited to be here with you. I'm just going to give you a brief overview, as my co-author said. So in the 1990s, evidence began to emerge that cannabis does have medical treatment and that it can treat a variety of ailments, including nausea, anxiety, glaucoma, depression. It is still federally Schedule I, which means that Congress has deemed it to have no medical value and a high potential for abuse. Other substances that are currently Schedule I are heroin, LSD, ecstasy, and peyote. So this is the class of drugs that marijuana is currently listed with. It's really the no currently accepted medical use that we're going to focus on, as evidence has emerged that this no longer applies to cannabis. Yeah, so 28 states and DC have to this point passed some form of a medical marijuana law. The first state to do this was California in 1996, and the laws actually vary a lot themselves. They vary in the ways that patients are given access to marijuana, whether it's dispensary or home cultivation. They also vary in whether caregivers are allowed and the amount of marijuana that people are allowed to possess. So there's really a lot of variation in the laws themselves. And this is the comprehensive literature review that came out in the past 3 weeks from the National Academies of Sciences, Engineering, and Medicine. And they created a committee to review 10,000 peer-reviewed journals to really evaluate the efficacy of cannabis as a medical treatment. And this is their results. So cannabis is an effective treatment for pain, nausea reduction, and spasticity, and this is conclusive. It is also effective for treating sleep problems for a variety of reasons, and this is moderate evidence for this. There's also some evidence that it is ineffective as a treatment for dementia, glaucoma, and depression. And there is insufficient evidence to make a clear decision about whether it is a good treatment for these other variety of ailments. And so this is really a statement from the most authoritative voices from the medical and scientific community that it is clear that cannabis does have a medical value and that it is an effective treatment for a variety of ailments. And so because of this, we expect that the federal schedule will soon change, and Georgia should move forward as if it will change soon. And I'm going to do quickly an overview about the spillover effects of cannabis. So first,
Ms. Bradford, I want to just make sure. So this study that has just been released 3 weeks ago, been peer-reviewed,
right,
and took a look at whatever
10,000
research
papers.
data that was out there, which is, you keep hearing that it's limited, but there is data out there, right?
Right. There's a lot of data
And
out
so, and it was clear, conclusive evidence on some of these conditions, but not conclusive evidence on other conditions. Is that correct?
That is correct.
Just to make sure we got that. Okay.
So just briefly, some spillover effects. Medical marijuana laws have seen to reduce traffic fatalities by up to 9%. This is likely due to a substitution effect away from alcohol consumption towards marijuana consumption or cannabis consumption. It's already been seen to reduce suicides in males, and it does not have an effect on the consumption of alcohol or other substances, which lends evidence against the gateway effect hypothesis. There's also some evidence of negative externalities of medical marijuana laws. For instance, it has been found to have an increase in arrests for men. And there is some disagreement in the literature about the effect of medical marijuana laws on cannabis use itself. So it has been disagreement both for young adults. You can see some studies that have shown positive and negative effects, and for adults. So there is some disagreement on the literature about the spillover effects on this area.
Okay, I'm gonna stop you again for a minute, because I've been doing this thing for 4 years, and I keep hearing different statistics saying that, you know, in Colorado traffic fatalities are up, and all the negative side effects. But if I'm reading your first slide, which I don't have the number of it, but the first one of the positive externalities, that there is clear evidence from this report that there is a reduction in traffic fatalities.
Correct. Yes, from 9 to 11%.
In the states that have medical cannabis legislation.
Yes.
Is that correct? Okay.
Yes.
Okay. Thank you.
Reese isn't from Colorado.
Oh, this is, this Anderson paper from 2013 was also in Colorado.
Okay.
And with that, I will move to my co-author to discuss our research.
Thank you very much. So in the face of this rapidly changing policy environment, and also the need for increased evidence, Ashley and I have undertaken a number of studies looking at the impact of medical cannabis laws on clinical use nationwide, and also on opiate deaths and accidental drug deaths, which these are two big issues. It amazed us, actually, that when we first started this process a couple of years ago, that nobody had yet asked the question, to what extent is cannabis being used as medicine? There's a lot of evidence from data sets about the use of cannabis. There's a lot of evidence about the treatment for the medical conditions that Ashley highlighted a minute ago, but very little asking directly, are people using cannabis in place of other medications? And so we actually undertook a series of studies to ask that question. The first of which came out this past summer in the journal Health Affairs, which is sort of the leading health policy journal in the country. We examined data on Medicare. So I'm going to go over two different medical use regimes: Medicare spending and Medicaid spending. This study looked at Medicare from 2010 to 2013. We've since been able to update it to 2014, and since we have more years, also look at this distinction in the type of laws, whether or not cannabis is being delivered through home cultivation or whether cannabis is being delivered through dispensaries. And actually, it turns out to make quite a bit of difference when we take a look at that. So in the sake of, for brevity, and also because I know that we're speaking to, we have a lot of people who want to speak and are journalists, I won't go into tons of detail unless you ask me about it afterwards. And then as an academic, I'm happy to provide you more detail probably than you have tolerance for. So the question that we're basically asking here is whether or not implementing an effective medical marijuana law changed the use of FDA-approved prescription medications. And when we say an effective medical marijuana law, we don't mean that there's just a law in the books. What we mean is that we've determined that, in fact, it's possible for the residents of the state to get access to cannabis in some form or another, right?
So let me stop you. So that would exclude states like Georgia. Is that?
It would exclude states like Georgia, and the reason it is in the slide that Ashley showed a few minutes ago. It's actually very recent that we've had states like Georgia turn on CBD or low THC oil options. So there's just not the data to assess that yet. Okay. So we're not saying anything positive or negative about that. All right. So one thing that we did do that I want to bring to your attention is that we are not looking at all drugs, and so this isn't comprehensive. The reason, of course, is that no one imagines that cannabis is an effective treatment for the flu, for example, and so we restricted ourselves to analyzing those prescription categories where there is some clinical evidence that cannabis might be an effective treatment, and so we would imagine a substitution effect. We were, by the way, basing this on the pre-existing evidence, not the report that came out 3 weeks ago from the National Academies of Science. That was too recent, though in future work we will use that. We use state laws and the clinical evidence to help us in this. We took a look at all prescriptions written for the Medicare Part D program from 2010 to 2014. That's a lot of prescriptions. We had 108 million drugs that we examined, or sort of drug categories, and we did analyses sort of at the physician level. Again, if you want details of the analysis, I'm happy to provide them later. And what we found were large and very significant effects of turning on medical cannabis laws on the use of these prescriptions in 8 of our 9 categories. And these were substitution effects. That is, when medical cannabis laws went into effect, the use of these drugs went down. So pain medications, anxiety medications, depression, etc. Prescription use for those fell when states turned on medical cannabis laws. If we just ask the question in terms of any medical cannabis laws, it ranges from about 80 to about 1,200 daily doses, the largest categories for pain. Once we take into account dispensaries versus home cultivations, those numbers triple. And so if a state turns on a dispensary-based distribution system for medical cannabis, for example, there's about 2,600 fewer doses per year per physician for pain medications. So the overwhelming portion of those are for opiates. So imagine here in Georgia, we've got about 11,500 primary care physicians. If each of those, if we turned on such a law, each of those reduced their pain prescriptions by about 2,500 doses per year. That's a lot fewer doses of pain medications, many of which are quite dangerous if used improperly, and are, of course, subject to abuse.
And Dr. Bradford, most of those would be opioid related, is that correct?
Would be opioids, that's correct. That's the largest proportion.
Right.
What does it mean in terms of money? It actually turns, and now this, of course, is money accruing to the federal government through Medicare. We'll come to the state government in just a minute. But actually, we estimate that about $150 million less Medicare spending occurred because of medical cannabis laws nationwide. If we imagined that every state turned on a dispensary-based cannabis law, of course this is not true, but we counterfactually imagine that, the Medicare program would have saved, we estimate, about $1.15 billion in 2014 in fewer prescription drugs. This is, of course, assuming Medicare is not buying the cannabis, which I don't think that there's much imagination of that happening in the immediate future.
Okay, I just want to make sure, let's hit that, just at that point. If we'd have said medical cannabis laws were in place, there would be
1.15 billion
less in spending for prescription drugs
in Medicare Part D
that have addictive potential.
A large portion of which would be that. Yes, that's right. The biggest category by far is pain medications.
Right. Okay.
So that's just Medicare, right? That's not counting Medicaid. It's not counting privately insured people. So we redid this analysis recently, looking at Medicaid. Now, again, remember that Medicaid is the program for low-income individuals, that the costs of which are shared by the states and the federal government, depending upon the state's per capita income. We essentially did the same process that I just went through a minute ago, and we found very similar results. But actually larger. Of course, it's a younger population, potentially more receptive to the use of medical cannabis. What we found is that in Medicaid nationwide, if states in their fee-for-service component of Medicaid, and I do want to emphasize we didn't look at managed care Medicaid, just fee-for-service, but we have seen about between the federal and state share in 2014, about $475 million less spending. The biggest category is pain medications, most of which are opiates. Right? Spending went down by about $475 million if, again, all states had turned on medical cannabis laws. Between the states and the federal government, there would have been about $1 billion less in fee-for-service Medicaid. Now, fee-for-service Medicaid only counts for about 25–30% of Medicaid nationwide. So if we extrapolate this to the managed care population as well, it would be a number of about 3 times bigger than that. So we're talking about a large reduction in spending, something approaching 1% of Medicaid spending at that point. What does this mean for Georgia? Well, if we just look at the fee-for-service Medicaid and Medicare Part D, what we'd see is that in 2014, if Georgia had a medical cannabis law, we would have Georgia would have saved about $9 million, a little under $9 million. The federal government would have saved for Medicaid just under $17 million. By the way, it would be about 36 million combined if we include managed care in our calculation. The federal government would have spent about 13 or 14 million dollars less for Georgia residents for Medicare. So the budgetary implications are non-trivial. We've also done some work with other colleagues at the University of Georgia, Grace Adams and Amanda Abraham, looking at the implications for opiate-related deaths, accidental drug deaths nationwide. We did this analysis looking at all counties in the United States annually from 2000 to 2014. And this is just a graph to sort of remind you of the severity of the problem we're facing with opiate-related deaths. There's this gigantic wave moving through the country of increased death. You see this starting in 2003. Each bar represents a death rate ranging from 0 to 2 per 100,000, all the way up to more than 20 per 100,000. And you see that the mass of death rates are increasing to the higher and higher ends over time. The question is, what happens if you turn on a medical cannabis law? We see that it means, from what we found in Medicare and Medicaid, fewer people use pain medications. Does that translate into fewer deaths? And indeed, what we find is that when you turn on a dispensary-based medical cannabis law, there are significant reductions, statistically significant and large reductions in the death rates associated with opiates in counties that are in states that have turned on dispensary-based systems. There is no benefit when you turn on home cultivation-based systems. So really the benefit in terms of opiate deaths seem to be accruing to having a dispensary as a delivery mechanism. So let me just jump to the end point here. Again, we have 28 states and an additional dozen or more that with some form of medical cannabis, either an oil or whole plant cannabis in place. That represents nearly 2/3 of the American population living in states that have this in place, functioning apparently quite well. Spillover seems to be modest. We have now, within the last 3 weeks, authoritative evidence from the medical community that there is, in fact, an accepted medical use, at least in some purposes, for cannabis, which would, on the face of it, require rescheduling away from Schedule I by the DEA. We find that when you turn on medical cannabis, you actually spend less because people use less prescription drugs, particularly pain medications. And when you turn on a dispensary-based system, we have fewer accidental drug deaths, most of which are opiates. So appropriate design medical cannabis laws can save both lives and money. And at this point, I will stop, and Ashley and I will be happy to answer any further questions you have.
Dr. Bradford, thank you. Boy, that is, to the members of the committee and to the public at large that's watching this, that is some significant. So let me just, and I'm a restaurant guy, so I just like to make it simple. If Georgia were to implement a medical cannabis infrastructure where citizens could access medical cannabis here in our state, per your study, we would see less taxpayer cost.
That's correct.
We would see less usage of opiates,
That's
including
correct.
Oxycontin, oxycodone, and we would see less deaths from drug overdose.
That's correct. All three of those are correct.
Okay. And Dr. Bradford, let me just, for the committee's sake too, you are a renowned UGA professor, is that correct?
I'm a UGA professor, yeah.
Okay. But I want to just make, you are, why don't you just give me your credentials very quick so we'll know
Sure.
who it is that's given us this information.
I am an economist, have a PhD in economics. I've been, this is about my 25th or 26th, amazingly, year as a faculty member. I've been director of university-level research centers. I'm now the George C. Busby Professor of Public Policy at the University of Georgia.
So you're a pretty darn smart guy. Yeah. And you have you derive no economic benefit from if there's a potential medical cannabis legislation passed in Georgia.
None whatsoever.
None whatsoever. Okay. I just want to make sure that's clear to the committee. Okay. Committee, we got a smart guy here with a lot of information. If you want to ask him some questions, now's the time to do it. Representative Evans. Okay, we're gonna keep working on this. Try it now. Okay. We're gonna keep going forward. Okay.
All right. Schedule 1 and what's not, if he stands to lose if it is or if it isn't. I wonder if you had any research information on how involved pharmaceutical companies that are involved in manufacturing opiates have been in keeping medical cannabis oil on Schedule 1.
Yeah, so it's interesting. You know, one of the when our article came out in Health Affairs this summer, it got a lot of attention. Actually, it turned out to be the sort of the most heavily discussed from a media standpoint article the journal has ever published. And we got a lot of calls from reporters, and that was the number one question that they asked us, which surprised me. Actually, I had not anticipated that at all. I was primed to answer other questions. And so, yes, we have looked into that since then. And I will say that while I don't know of research or credible media coverage myself of attempts to influence the DEA, I will say that there is evidence that drug manufacturers have contributed significantly to campaigns to keep medical cannabis and recreational cannabis from being approved in the states. For example, this past year there was an expansion move in Arizona for medical cannabis, and the largest manufacturer of fentanyl, which is an incredibly dangerous, I mean, it's a powerful, important drug for people with breakthrough pain for cancer, but it is, as a drug of abuse, an incredibly dangerous drug, and one that is going to be a big problem for us in the immediate future. That manufacturer contributed about $500,000 to opponent campaigns to prevent cannabis liberalization in Arizona. There is, the Associated Press has done an interesting study on this. If you're interested, if you contact me, I'm happy to send you evidence and data, and there's quite a bit of money that has been going into the states as political contributions from pain medication manufacturers to sort of prevent expansion of cannabis, medical cannabis into the states. Yeah.
Representative Evans, test your mic real quick. Representative Evans, just no, still not. Okay. Okay, Representative Beverly.
Fascinating study, thank you. In the idea that THC is lowering opioid abuse, is there anything in your research that says that people using sort of THC oil are also using opioids and the sort of synergistic effect, like create this pain cocktail? Is there a sort of morbidity or mortality rate that's associated with sort of people combining drugs, creating this cocktail, and then all of a sudden we have a spike, maybe not in deaths, but maybe emergency mode?
Right. That's an excellent question. I will first, of course, my first response to that is going to be that I'm an economist, not a clinician, and so I don't want to step outside my range. I understand you are a clinician, is that right? Yeah. So I think you'll be much better able to address that particular aspect of it. I will say that there is very little research on the observed use of opiates and marijuana in sort of population levels like the data that we did, because there aren't data sets that actually ask people systematically, let's track your Medicare spending, let's track your prescription drug use, and are you using marijuana or other such products. So it's really hard for us in the research community to systematically answer that outside of small studies that academic clinical researchers might conduct, and I'm not familiar with that literature.
Representative Gravely.
Thank you, Mr. Chairman, and I apologize.
First row.
For being tardy. Yes, sir. Yes, sir. Baptist. And maybe a clinician may be the best time for me to pose this question, so I'll wait unless I should do it now.
No, fire away. We got him here.
I guess you're into studying trends.
Yes.
Correct. Well, I noticed a trend over the last 3 years. As in the legislature, we get publications from everyone under the sun. Yeah. Even the Scientologist sent us some stuff that had epidemic on it. Capital Ideas, one of the most recent versions of Capital Ideas, opioid crisis. Every one of them. Georgia Pharmacy, bitter pills, the opioid crisis, addiction, opioid. Our medical school here in Georgia, one of them, I should add. I found it interesting, and I just didn't know if maybe your research saw any of this. because I saw a trend, the opioid crisis, the death, and then as I started listening to what you were saying, based on the stats in the different states, in one of the articles it said 90% of new heroin users made their way to heroin via prescription opioids. Is that something that maybe your research, as much so, if I may continue, I'm sorry. So much so that in late March, the FDA required all short-acting prescription opioids to carry boxed warnings stating that the drugs increase the risk of misuse, abuse, addiction, overdose, and death.
Yes, I think that I mean this is an area that I do study. I have a sort of long-standing research interest in pharmaceutical industry generally, and ironically in boxed warnings, and there does seem to be significant evidence and growing evidence that one of the primary pathways to heroin addiction is through people who get legitimate prescriptions for opiates in response to dental procedures, surgeries, acute injuries, and that because of course these products can be highly addictive if they're not used exactly correctly, people are progressing on to heroin. The primary reason, ironically, is an unintended consequence of a very well-intentioned attempt by the states to try to restrict this. And so what has happened in the face of opiate prescription abuse is that states have implemented prescription drug monitoring programs. They've implemented regulations to oversee pill mills or high-volume prescribers. They've implemented restrictions on requiring physical exams and tamper-resistant prescription pads, all in the attempt to constrain access, illegitimate access to opiates. The consequence has been that it's pushed people towards the unfortunately lower priced alternative, which is heroin. And so heroin is an opiate. It's derived from the opium poppy, just like morphine, just like synthetic opiates such as fentanyl. And as states have tried to control opiate abuse with their policies, that's actually pushed people to the black market for heroin instead of the black market for prescription pills, which are harder to get now. And as a consequence, we're seeing people dying, and dying in places that just haven't had to deal with heroin in the past, and so aren't really as equipped potentially from a policy perspective to react to it. And as I said, one of the really alarming recent trends is that fentanyl is becoming a drug of abuse. Fentanyl is approximately 100 times more powerful than morphine, about 50 times more powerful than heroin. About 1 million doses can fit in a shoebox. And it's now being manufactured by cartels primarily Mexico, and it's easy to transport, and as a consequence, it's a lower cost drug of abuse. It cycles through your system in about 4 hours, unlike heroin, which might last an entire day. So the opportunities for overdose are frequent. The margins of error are small, and I think that we're probably on the cusp of a really alarming spate of deaths from fentanyl. And any tool that we can bring to bear to control that before it gets out of hand, I think we really need to consider quite carefully.
Would it be safe to say that the misuse of an opioid, it could be labeled as a gateway drug? Would that be going too far? I mean, if it says 90% of new heroin users made their way to heroin via prescription opioids.
Well, I guess I would say that the misuse of an opiate is in fact illegal drug use, and it comes with all of the risk of death and the need to, to support a heroin or an OxyContin or a fentanyl habit requires a lot of money, and also destroys your productivity. So it's both something that increases the risk of death, and it for communities increases the chances of property crimes, at least, to support the habits that these individuals have. Yeah.
Thank you. No more questions, Chair.
Okay. Any other questions from members of the committee? I don't see any. Dr. Bradford, thank you so much for being here.
Thank you very much.
This research is compelling and really have a significant impact, not only for our state, for the entire country. And so we're proud of the work you're doing there at UGA, and we may call on you again.
We'd be happy to come back.
To provide this. So thank you very much. Appreciate it.
For sure. Thanks.
Okay. to the members of the committee and to those that are here that want to testify, we have about 10 to 12 folks that want to testify. Okay, it's 4 o'clock. We're going to be out of here by 5, and if we desire to want to move on the bill today, we're going to need to run through these fairly quick. So here's what we're going to do. We're going to allow folks who are here and want to speak, but I'm going to give you about 3 or 4 minutes. So you need to hit your points quick. Tell us, again, if you're here to talk about a particular condition that we are debating adding or potentially removing on this under current Georgia law, tell us why or why not you don't you want that what your position is. So please be very brief and very concise. Okay, everybody good with that? And we'll move quickly. Okay, first up, we're going to have Rick Ward, who represents the Academy of Pediatrics, I believe, is here. Rick, are you here? Yeah. Okay. Yeah. And so if you'll tell us who you are, whether you're for or against the legislation, and then briefly tell us your basis for or against.
Thank you, Mr. Chairman, members of the committee. I'm Rick Ward. I'm the Executive Director of the Georgia chapter of the American Academy of Pediatrics. We represent over 1,800 general pediatricians and pediatric subspecialists around the state. I'm going to confine my remarks regarding House Bill 64, I believe.
65.
65, sorry. In terms of the addition of autism spectrum disorders as a medically qualifying condition. And I guess before I begin, I want to commend Mr. Chairman, your diligence and thoroughness on this issue. The chairman has talked repeatedly to a highly respected member of my executive committee in Macon, a pediatrician, and he's examined every corner of this issue imaginable. So our hat is off to you in that regard. Having said that, regarding just the autism spectrum disorder and the addition of it, we cannot be supportive of that at this time. For the simple fact is no current medical research exists proving that medical cannabis, even a CBD oil of whatever THC concentration, would be an effective treatment for autism disorder. And if you look at the math, there theoretically could be about 10,000 children in the state that would be impacted by autism and theoretically could be seeking this oil, for which there is no bona fide studies to support it. We were encouraged, just incidentally, by the good progress that's going on at MCG in Atlanta and Savannah on these studies about seizure control in children with epilepsy whose seizures are not controlled by medication. And we just heard a report last night from a pediatric neurologist in Augusta who's leading those trials. Those are very promising, so we're encouraged by that. But the fact is, with regarding autism, no such science exists now, and we couldn't support that. We wouldn't comment, of course, on the other conditions in adult medicine.
Okay. Okay. Thank you, Mr. Ward. Hang on. Are there any questions for Mr. Ward? Feel free, members of the committee, to ask questions. That'll delay us a little bit, but if you got questions, then now's the time to ask them. So. Yep. Representative Chairman Dipsey? Nope. Okay. Representative Beskin.
Thank you, Dr. Ward, for coming here today.
I'm not a pediatrician.
Yeah.
I'm the hired help.
Then I was going to ask, I thought you were a pediatrician, and I was going to ask if you had any patients, but are you aware of any patients of your pediatrician members who have benefited from the use of the oil over the last couple of years?
For what condition? Oh, yes, absolutely. As I said, Dr. Park, a pediatric neurologist at MCG, reported to our committee just last night. They've been at this a couple of years. I think they have over 50 patients involved. The studies are very promising that it is an effective therapy to modify or reduce the number of seizures that these kids have.
Okay. Representative Evans?
We weren't directly supportive because our position is we only support these kind of things if they're done in scientifically controlled academic trials. And so technically we weren't supportive, but there was enough experimental and anecdotal evidence out there that our position was it deserves to be studied. And the effect of Representative Peake's bill last year or 2 years ago, I guess, was that it allowed for it to be studied. And then it also spawned these research studies in Augusta mainly, and then Savannah and Atlanta.
Are you aware of any studies going on right now for the effectiveness of the cannabis oil in treatment of autism spectrum disorder?
We are not. And as it's been pointed out also, the FDA really hurt us this summer by keeping this on Schedule 1. If they had moved it, then it would open up more research opportunities to see if in fact this is an effective treatment for children with autism. But being on Schedule 1, we're kind of handcuffed on that. Maybe the new administration will change that.
Okay. Mr. Ward, thank you. I appreciate you being here in testimony. Okay. Next up, we've got Mr. Dale Jackson. And I have a feeling he may have a different stance. So. Mr. Jackson, you want to come chat with us?
Hey, Dale, how are you? Hey, how's it going?
Again, if you'll keep your comments brief.
Unlike, unlike my, yeah, I will. Many of you know my story. Many of you have seen me here before. And I could tell the story of the countless single mothers that contact me on a daily basis that are faced with the decision of having to give up their autistic child to the state because they cannot handle one more night of being beaten by their 18-year-old or 15-year-old son. I'm not going to tell you those stories. I'm going to tell you one story, and the most important story to me, and that is my son. March 7th, I began illegally treating my son with cannabis oil. At that time, he could not speak. He could not eat his food by himself. He could not go to the bathroom. He could not tie his shoes. My son could not communicate with me in any way. My family was unable to visit a restaurant because he couldn't handle the noise. Now, months later, one video shows it all. When I sat down on the floor in front of my son across the living room, and I asked my son to come here, my son recognized my request. He got up, he walked across the room, and he communicated his love for me by giving me a hug. And then he turned around and went and played with his toys like a normal 8-year-old child. My son can still not talk, but for one night, and from now on, my son can communicate his love for me. And as a parent, that means everything. Autism needs to be included, and there doesn't need to be any age restriction. And I have seen firsthand that it needs to be 5%. Thank you.
Okay, Mr. Jackson, any questions for Mr. Jackson? Glad to hear the positive stories for your son. Are you concerned about any negative effects from medical cannabis oil that maybe we don't know about since it hadn't been studied enough?
Well, in short, no.
Okay.
But just because someone may testify that there is a possibility of a 8% reduction in IQ level, my son is a lot smarter thanks to cannabis oil. And that's the reason why we are treating him with cannabis oil, is for cognitive development. I started a school 2 years ago for him. He's been in that school for 6 months without cannabis oil. He's been in that school with the exact same therapies with cannabis oil. And every single one of his teachers, one of them happens to be my pastor's wife, will testify that the change has been remarkable since he started cannabis oil.
Okay. Okay. Thank you, Mr. Jackson. Appreciate it. Mr. Brian Underwood. Is Brian here? Brian, good to see you again. I know you've been here and testified several times before. Glad to have you back.
Thank you for having me.
If you'll briefly tell your story,
Okay.
that'd be great.
I had some pictures, but they paint a very good picture, but I'll gladly send them to you and show you why my son needs legal access to cannabis oil. My name's Brian Underwood. My son Reed Underwood suffers from a very rare and painful genetic skin disease called recessive dystrophic epidermolysis bullosa. It's called RDEB, or a broader name is EB. This disease, when he was born, he was missing the protein that binds the skin together. And you can think of this protein as like Velcro. And without this Velcro, the skin can blister or come completely off at the slightest touch. It can happen anywhere on the body externally. It can also happen in the esophagus, the mouth, and the eyes. Reed doesn't eat by mouth. He has a feeding tube because he can't eat regular food like regular people. And as you are probably aware, blistering can hurt anybody. Everybody's probably gotten a blister from working in the yard or wearing shoes that are the wrong size. Imagine this all over your body, not having skin on your back, hands, or legs, open wounds that never heal. The pain that Reed deals with is unimaginable. You cannot comprehend what he deals with. I can't comprehend it, and he is my child. Words absolutely do not do it justice to describe how horrific this disease is and the damage that it inflicts. The life expectancy for kids with severe EB is not very long, but Reed underwent a bone marrow transplant 2 years ago as part of a research trial at the University of Minnesota. We're hopeful that this is going to stop the progression of the disease. Cannabis oil is incredible for kids with EB, and especially the level of pain that Reed deals with. CBD is incredible for keeping inflammation down, and it helps the skin to heal. THC helps with pain, and some strains are effective at helping itching, which is horrible for kids with EB as their skin is always trying to heal. Some people have been opposed to THC, which is absolutely ridiculous. Reed used to take methadone, morphine, Dilaudid for pain. He doesn't take any of those pharmaceuticals anymore. To be honest, there shouldn't be any limit on THC, as it only hurts kids like Reed. Cannabis-infused creams do more to heal his skin than any pharmaceutical company can concoct. No one in the Georgia Assembly, knows what Reed deals with, so why should anybody have a say in his medical decisions? To hear medical professionals in the Georgia Assembly say that cannabis has no medical value is astonishing. It is absolutely ludicrous that cannabis is even being debated, as it is an extremely safe medicine. Reed's doctor at the University of Minnesota, Dr. Jacob Toller, is a brilliant physician and research scientist. He is in full favor of Reed getting access to cannabis, as he knows nothing else will help. He once likened EB to being burned in a vat of hot oil in an interview with 11 Alive. He knows that cannabis oil works. Cannabis oil does work, and the law needs to be expanded to include intractable pain. We need legal access to cannabis oil, and allowing cultivation in Georgia would make that a reality. Forcing parents to find oil in our current situation is unacceptable. It is extremely expensive, and Reed should have access to strains that'll help. Please make this possible for my family, as you wouldn't let it happen to yours.
Mr. Underwood, thank you. If there are questions, let me just, if I can ask just real quick too, if you don't mind me asking. So you are currently providing medical cannabis oil to Reed, even though he does not meet one of the qualifying conditions here in Georgia. Is that correct?
Correct.
And to the best of your knowledge, EB, as we have defined intractable pain in the bill, would qualify under that condition. Is that correct?
It definitely should.
So your position would be that an individual like Reed would qualify under intractable pain?
I can't think of anything more painful than what he goes through.
Okay, thank you. I think we have one question for you. Representative Gravely.
Thank you, Mr. Chairman. Could you, thank you for your testimony. I hope how's Reed doing right now?
He's okay. I mean, he's 2 years old, so he wants to be like any other 2-year-old, and
Absolutely.
with that comes damage, and he's wanting to play, and it's hard.
And that goes to the point of my question. Reed's 2 years old. Could you tell us again would it be those are opioids he's taking, correct, for pain?
No longer.
No longer, but they were, correct?
Correct, from day
Could you
one.
tell me again what the opioids were?
Morphine, methadone, Dilaudid.
Methadone. Could you tell me, how do you dose a 2-year-old on those particular drugs?
Well, the pharmacist just dosed by weight, so
Those are powerful.
extremely, and we will never give them to him again.
So the same opioids that the FDA required all short-acting prescription opioids to carry box warnings stating that the drugs increase the risk of misuse, abuse, addiction, overdose, and death, correct?
Correct.
And you are standing here as the father of Reed saying that after being on morphine, methadone, and what was the other one, Diloxin? Dilaudid. And the THC cream has worked enough or has had such a positive reaction that you no longer need to give these to your son.
Well, we give oil orally.
Oil orally.
And
that
topically.
works.
100%.
100%. Thank you for your testimony, sir. No more questions.
Thank you, Representative Guy. Mr. Underwood, good to see you again. Thank you for being here, and appreciate it. We may need you some more too. So,
Thank you for having me.
Okay, next we're going to keep moving, gang, and I appreciate the brevity. And Harrison, Harrison, I don't know your last name, so you have to help me. Come on up, and if you'll tell us your last name.
Yes, sir. Good to be here. My name is Harrison. Last name is Couch.
Couch, okay. All right. Mr. Couch, why don't you briefly tell us your story?
Well, I'm 25, and in 2011, I was finishing up my first semester of my sophomore year of college when I was diagnosed with a disease called acromegaly that came about with a brain tumor about the size of a walnut that was discovered on my pituitary gland. That was quickly followed by surgery and radiation, and I'm still doing countless other treatments to take care of my health. Shortly after radiation, I started experiencing horrible migraines. And I tried calcium blockers and triptans to monitor my migraines, to no avail. I then found a pain management facility in Georgia where I started taking prescription opioids. I started on 10 milligrams a day, but tolerance increases and with that they increase the dose. 10 milligrams a day turned into 30 milligrams a day, and over the course of 3 years of being on dependent on opioids, I was taking far more a day than I care to admit here. Well, one day I reached a point where I realized either A, I was going to die on this, or B, I'm just going to quit it and try to take a new path. It's, you know, anyone who's been on medicine like that for that long realizes what it really does to your body. So shortly after stopping the medicine, I was weaned off the medicine, and my dad suggested trying medical cannabis oil. It had never occurred to me, but after stopping the opioids, I was bedridden with migraines for days on end. I couldn't work, couldn't hold a job, couldn't finish school. I was an economics major, still haven't finished school because of this. About a month ago, I tried medical cannabis oil for the first time, and I use it every evening, and I have ever since, and it's done wonders for me. And my dad's noticed improvement. Before this, for 4 consecutive months, I lost weight. I'm about 40 pounds under my healthy body weight, and this last month, for the first time in 4 or 5 months, I've gained weight back. I'm sleeping throughout the night. I'm able to continue my social activities. I haven't had a migraine that's kept me awake ever since I started. And let me be clear on that. The migraines that I was experiencing would literally keep me up at night 5 nights a week. Sleep was nothing more than just how many naps I can get in a day when I was feeling well. Medical cannabis oil has helped me a lot. Now I'm in the process of getting the card. I've had to take it illegally, and so my doctor's on board with me. I'm trying to get that worked out as we speak. But he brought up a good point. I apologize, I don't know your name, but he brought up a good point. People like to talk about how marijuana is a gateway drug, and from my perspective, oxycodone is the gateway drug. I realized that the day I quit taking this medicine, and I'm now trying to get my life back in order after finishing up treatments for my medical issues and stopping the opioids, and I'm feeling better now. But I had a 7-minute speech prepared that I'm trying to cram down to 3. So, I appreciate y'all having me. I really appreciate y'all having me. I hope I made some effect. If y'all have any questions, I'd be more than happy to answer.
Mr. Couch, thank you. That's really good. Don't go away just yet. Let me just make sure I understand, because this is a kind of important issue as we debate this bill.
Yes.
Your criteria, while you had cancer, a tumor,
yes,
for all practical purposes, would have not been considered severe or end of life. Is that correct?
Partly. Okay. So it was not a malignant cancer. It was a slow growth tumor. That being said, I had emergency surgery to have it removed. It very much was a life or death situation.
Okay.
Chronic pain, sleeplessness are the criteria that I am applying for the card.
Okay.
My doctor is entering chronic pain and sleep problems, weight loss.
My point of asking that is that you maybe would have slipped through the cracks potentially, because if the current law stays in place where cancer has to be severe or end stage, you potentially would slip through the cracks.
After speaking with my doctor, I could absolutely tell you I would have slipped through the cracks.
Okay.
Yes.
Where if HB 65 passes, therefore that qualifier is taken off, and as well as intractable pain added, you would meet that qualifier as well too.
The intractable pain, that's the niche that I'm trying to get qualified for, because I did not qualify for the cancer part.
Okay. Okay.
Yes, sir.
Any questions for Mr. Couch? Thank you. Appreciate you being here. Glad to hear Better Days Ahead. Okay. Ted Metz. Yes, sir. If you've got a few minutes, and just tell us briefly why you're here.
I believe that I can make this rather brief. Okay. I am Ted Metz. I have studied microbiology, biology, organic chemistry at the University of Georgia, and nursing at DeKalb College back before the turn of the century. And so I'm here before you today as a scientist, talking as a legislator. Right now, Georgia recognizes other states' driver's license, concealed weapons permits, and all these other things under Article 4, Section 1 of the Constitution, which is basically the reciprocity clause. Can you at least put into your bill a clause that recognizes all of the legality granted by other states to patients from other states who are in Georgia? Because it seems natural to do that, since we're already recognizing their driver's license, their concealed weapons permit. Why not allow in the bill, or sneak it into some other bill that's a must-pass legislation, to allow
well, that never
other states' patients to be fully recognized with full immunity from the criminal code of Georgia? That's my simple request.
Okay. Okay.
Any questions on that? Because my other point is that in this whole debate, it seems like we're focusing more and more on why should we legalize medical cannabis, instead of what the real question is, why was it ever illegalized in the first place? And I'll stop there.
Okay. Any questions for Mr. Metz? Mr. Metz, thank you. Appreciate it. We'll sure take that under advisement. Thank you. Yeah. You have a question? One question.
Is there a specific condition that you're talking about that is not on this list?
All I'm saying is that other states' medical laws for a other state's patient should be recognized in Georgia with the same full immunity from any Georgia statute that the person from the other state with a legal card would enjoy in Georgia. And to make that case, there was a recent case in McIntosh County. A man named Pereira from Massachusetts with his legal medical card was pulled over and charged with possession. He went to court. The judge said he's doing something that's legal in his state, and he dismissed the case, which is proof to Article 4, Section 1 of the Constitution actually being the key piece of legislation that would allow you to offer reciprocity to all other state card holders.
Okay. Thank you, Mr. Metz. That's your question. Okay. Angela Simmons. Oh, I'm sorry. You had one more question.
That begs a good question. Let's say someone from another state that has a medical cannabis card, and they're going to the beach, Their family is in the car with them. They're headed down to the beach. They come through Georgia. They're pulled over, and they have what is considered to be appropriate in their state. They're licensed from their state, and they get pulled over. What would happen in our state?
Unless they have a low THC oil registry card issued by the state of Georgia, they would be in illegal possession of the product.
But they can carry a firearm.
Yeah.
And we consider...
There is no reciprocity in our bill, in
So
the current law.
So a family coming from, let's say, Minnesota, driving down to Florida, they have a child with them. It doesn't matter. They have a family member. They have or to visit family in Georgia, to come and spend money in our state, which is what we ask everybody to do.
Yeah.
Would be in possession of a medicine recognized in their state, licensed in their state, would be arrested in our state.
They would have the potential of being arrested for carrying an illegal product. That's correct. So it's clearly something we need to look at and debate in this committee. And Mr. Metz, I appreciate you bringing the point up. Angela Simmons. Okay, we've got about 7 more folks, so I'm gonna ask everybody to come speak your issues. Okay, we're glad to have you here. We appreciate you coming and testifying.
I'm Angie Simons. I'm from Soperton, Georgia. I was a med-surg nurse at the VA in Dublin for most of my life. I had been having migraines, which was very unusual, but you know, I was seeing about my patients. So I ate a pack of crackers and I ate some more goody powders and I had it under control. And my patient said that I had asked him repeatedly the same question, and I kept entering into the computer. But he, thank God, knew me. And so he went and got the doctor. And when I came to, I was in St. Joseph in Savannah. The lupus that I had recently been diagnosed with caused me to have vasculitis, which ended up, I had a stroke. So I nearly lost my life. When I woke up, I couldn't speak. My handwriting still looks like chicken scratch. Sorry about that. But I'm working on it. Speech therapy, physical therapy. I do have a wonderful carbon fiber leg brace because apparently autoimmune diseases, which most people do not realize, they're kind of like a bag of Lay's potato chips. They just multiply on you. You know, you wind up, you have rheumatoid arthritis, you get lupus. Oh, next it's myasthenia gravis. What else could possibly happen to you? I saw the children, the seizure children. I saw them, and I started researching because that's what medical people do within our ability. We try to make our own choices and our own decisions. And I decided, you know, this is a neuroprotectant. What could it possibly, conceivably do for somebody in my situation? Could it help me fight back from this stroke? Could I get part of my life back? And indeed I have. Last year, sir, I made a picture with you in the lobby. I was on a rolling walker. The guys had to help me up and down. Dale Jackson, Vince, and all the guys, they helped me up and down the steps because I was too give out to go all the way around to the handicap ramp to get into the building. And so I would say to everybody, if you want to talk about cost effectiveness, I was able to wean off of high doses of steroids. I haven't had any more collapsed lungs. I did wean off the steroids. I have not been hospitalized since, y'all are gonna love this, I embarked upon my cannabis oil journey because I figure I'm a fool. I'm surely going to prison. So on April Fool's Day of 2016, in my crock pot in my kitchen, thank you, Lord. You can YouTube it. You can find all kinds of information on there. Most of the stuff on the internet's a bunch of crap. It's harmful. But there are occasionally golden nuggets in the midst. So my quality of life And I take exception to the end-stage language that is in the current legislation. I feel perhaps if people were allowed to access this sooner, perhaps they would not progress to end stage. I don't want to move away from my home. My family has served the military for generations, and I believe their blood has bought and paid for my freedom. And I believe it's a basic human right to have a decent quality of life within certain limitations. I'm never going to be cured, but I can have a decent quality of life and feel like a human being again and actually sleep some at night. Because I'll go something about the lupus and the inflammation in my brain. Literally, I can take nothing but cat naps for weeks. And the more lack of sleep you experience, literally, the crazier you get.
Yeah.
I mean, I don't know any other words to say it bluntly. I mean, you just feel like you're bouncing off the walls.
Yeah. Ms. Simons, let me, if I can just, would your medical condition that you have now, and we're not going to ask for any more privacy details, but would it meet the criteria of the new conditions that we're at? So
No.
it would not meet an intractable pain condition?
That probably would, because
Okay.
the lupus has eaten my internal organs. I have a lot of kidney pain.
Right. So possibly it could fit under the intractable pain
I'm
condition?
hoping so.
Yeah. Okay.
But there's so many autoimmune diseases, and I'm hoping that we can get help either through coverage through intractable pain or however way we need to get it, because this is valuable medication. I don't shoot dope. I don't smoke dope. I make oil. I'm illegal. I'm in fear that I'm going to prison every day. But I came down to the choice, well, you're taking CellCep, you're taking all these steroids, you're doing everything in your power to do what your doctors tell you to do. Everything. And you're dying.
Yeah.
So basically, what else you got to lose?
Yeah.
Try the oil, and I did.
Okay.
And I thank y'all for letting me speak my piece today.
Thank you, Ms. Simons. I appreciate you being here.
And
Thank
y'all
you
have a good day.
thank you for sharing your testimony. Appreciate you traveling up from Soperton too. Lori Murphy. Yes, ma'am. Welcome to our committee. And why don't you tell us
Thank
your
you.
story real quick?
Thank you for your time.
Yes,
today.
ma'am.
I'm just going to read this and make it real
Okay,
quick.
sure.
So my name is Lori Murphy, and I survived a thalamic stroke on June 21st of 2006. My stroke was due to birth control, a hole in my heart that never closed as an infant. It's called a PFO, patent foramen ovale, and a rare blood type that is hereditary called factor V Leiden. Which is factor V Leiden is a blood type that's predisposed to clotting. About a month after my stroke, I started feeling a burning sensation in my arm and on the inside of my stomach on the left side where my stroke affected me. An appointment with my neurologist confirmed the burning sensations, and I was diagnosed with central pain syndrome, or also known as thalamic pain syndrome. This quickly turned into a debilitating pain that runs head to toe on the left side of my body where my stroke affected me. Because of where my stroke affected me in the brain, in my thalamus, there was damage done to the central nervous system. So fast forward 10 plus years, I live and have lived in pain every waking moment. My body burns on fire. I feel like my hand is stuck in an electrical socket. Sweats, vomit, pins and needles, hurts to touch me, hurts to wear pants rubbing against my leg when I walk, to be cold, to be hot, the list is too long. I forget what it's like not to be in pain. I've had one good day in the past 10 plus years. On the pain scale of 1 to 10, a normal day, not including my triggers, is a strong 6 or 7. When my triggers are included, I would say it's a strong 8. This is every waking moment of every single day of my life. Sorry. I have been treated like a guinea pig, trying medication after medication. I've been on narcotics until now I seem to have built a tolerance to them, and I get very ill when I take them. I've done IV infusions of lidocaine and other drugs. I did a 4-week series of ketamine IV infusions with no relief. Acupuncture, vitamins, chiropractic care, the list goes on. I take a heck of a medication cocktail now, but that is what is so frustrating now is the medications I'm being prescribed I can't afford. The most recent one prescribed to help my pain was $345 a month. How can a person on disability afford that? Much less anyone working the average job in America. So I've seen a neurosurgeon at Johns Hopkins, pain management at Shepherd Pain Center. Again, I have seemed to have run my course and exhausted my efforts. Except one. That one good day I mentioned, I had consumed some medical marijuana that day. I felt some relief. It knocked the edge off. For once, I felt okay in 10 plus years. I firmly believe in the use of medical marijuana in the relief of my chronic pain, central pain syndrome. And as I said, central pain syndrome is a pretty unknown disease, and it's categorized as a rare disease. So that's where I stand.
Ms. Murphy, thank you for being here. Let me ask you, would your condition you think would meet the criteria of intractable pain as written under the current law, under the law that we're considering?
Without a doubt.
Okay. Ms. Murphy, thank you for being here. Any
Yes.
questions from the members of the committee? Thank you.
Thanks.
Stephen M. George. And thank you to those who have testified so far, keeping it brief. I'm going to ask the remaining ones we have, continue to keep it brief to see if and then we'll see what the committee wants to do as far as action on the bill. Mr. George, glad to have you here.
Yes, sir. Thank you. I live in Cobb County, Georgia. I'm also the primary caretaker for my grandmother, who happens to be the official state of Georgia great-great-granny.
Okay.
And she is a medical marijuana patient. I have PTSD and a traumatic brain injury. I'm a veteran. I was served in the paratroopers, served with the Ranger Infantry, 75th Rangers. And I can assure you that my physical condition today is a direct result of the things I did willingly, that I volunteered to do for this country. And my grandmother is ready to go home. My mother has degenerative disc disease. She actually had to have some sort of operation where they injected surgical cement into her discs to keep them from collapsing. And I can assure you, she is in pain, I guess you would call it intractable pain. My grandmother, I can tell you this much, that I went to the doctor to try to get her the CBD oil card. The doctor told me that there was no clinical findings that suggested the CBD would help. At the time, Crohn's was the only disease that she would qualify for under the current law. For whatever reason, the doctor chose not to prescribe her that, but he did prescribe her the medical marijuana pill Dronabinol. I can tell you this much, that her worst days now are better than her best days used to be. And people in the family, my neighbors, the pastor, the churches, anyone that deals with my grandmother would agree that there is something going on there. And I will quote my grandmother now when she was honored on her birthday as the official state of Georgia great-great-granny. The governor asked her, well, what do you think, Miss Margie? She says, I'm just an old lady. I don't know what all the big deal is. He says, well, don't you have anything to say? She goes, well, I'm not very smart, but I do know, depending on what kind of diabetic you are, sometimes sugar's your medicine. And I mean, I was just shocked. I mean, it was just sometimes, she can be just as clear as a bell. And I believe that must have been one of her clearest days ever, because actually that's right. I mean, sometimes sugar is your medicine. So anyone who says that cannabis isn't medicine, I think they need to really think hard about what they're doing. And besides that, if there is no legitimate use for cannabis, how come as the U.S. Patent Office issued patent number 6650307? In order to get a patent, you have to do two things. You have to prove that what you want to patent works, and you have to prove there's a legitimate need for it. And with that, I would just say thank you, and I would encourage you to also add degenerative disc disease as well as dementia and partial dementia to your list of symptoms.
Okay.
Thank you.
Mr. George, I don't see any questions. Thank you for being here. Thank you for your service to our country as well, too. Michael Harris. Mr. Harris, glad to have you here.
Hey, how you guys doing today?
Doing good. Why don't you briefly tell us your story?
Well, my name is Mikhail Harris. Everybody calls me Coach. A lot of you guys probably know me from walking the halls talking about industrial hemp. But today, I just want to tell you a little bit about my story, why I come to the cannabis hearings. I've been in the cannabis industry since 2013 in Denver, Colorado. Our company is LLC out of Colorado, and since then I have been coming across a lot of individuals dealing with the medical industry as far as things going on. Matter of fact, when we testified at the Black Caucus, I think we were talking about prohibition of information, saying that all this information that people said are not here is here. It's available. I mean, not available, but it's kind of like you have to do research for it. But the last research that we came about was Stanford University study, and we still have not, in these proceedings, talked about any of those or any of that information that is out there. I'm also a military veteran. I'm a Navy veteran. And my personal story is I have 3 people in my house. One has a brain aneurysm. My significant other has a tumor the size of a grapefruit on her head, which is going down now. And her mother has been fighting breast cancer for 23 years. So with all this I'm constantly coming up here trying to figure out ways to make Georgia a better Georgia. Now, we talked earlier about safe access, and I think Mr. Peake knows I've been in this office almost every day this week trying to talk about how can we get to this point of safe access. I want to make sure PTSD is on the list, most definitely. But I'm glad that you guys did, for a brief moment, address giving us safe access.
Yeah, and we will address the cultivation issue another time. So,
yes, sir, most definitely. And most definitely, and then I hear certain people on the board saying are people in this room saying they have access to the medication. We don't. I would like to know where. Thank you very much. You have a good day.
Mr. Harris, or Coach, as we know you, thank you. Appreciate your testimony. And I'm going to apologize, Avet Iyasu. Yeah, excuse me if I butchered that. And why don't you tell us your name and share with us your story?
Thank you, Mr. Chairman. My name is Awad Iyasu. You got it right.
Close enough.
And I'm also a councilman in the small city of Clarkston. But I'm here today to share my story, story of my son. My son is 12 years old now, and he suffers from partial autism. He got diagnosed when he was 4 years old, I believe, and when he was 3 years old, we realized he was lining his toys in a certain order, and we were so heartbroken because we didn't really know a lot about autism at that time. And we've done so much. We've done speech therapy, we've done occupational therapy, and thankful he's doing a lot better. But I know his potential. I can see he's a mathematical genius, but he lacks on simple basic cognitive skills and I believe medical cannabis could possibly help him. We never tried to give him that medicine so far, and I know some people have tried it. And the thing is, being a parent, as any other parent would do, you always are always thinking, what can I do to make him feel better, to make him whole? And I always have that guilt in my mind, and even though he's doing a lot better, I always feel that he could do a lot better. And I know that if he does a lot better, it's a lot better for my family, and it's going to be better for our state of Georgia, because if my son is a productive member of society, he will not have to depend on the state for any help, and he would be very productive. If I brought him here today, Mr. Chairman, you can tell him your date of birth, and he would tell you if it was Monday or if it was Tuesday, even if he doesn't know you. But he still lacks certain cognitive skills that any average person would be able to do. So please make sure to include medical cannabis. I know some people said it has not been proven, but I'm sure they can't tell me a single pill that would help him. If there was one, I'm sure all the people who are suffering from autism, whose children are suffering, would have used it, but there is none so far. So I think that's not a good argument just to say it's not been proven to help, medically speaking. But when I hear that some people are telling me that their son is feeling better, I think that's a good enough for me. Yeah. And thank you. Please make sure you include that. Thank you.
Thank you so much. Any questions? Thank you so much. Appreciate you sharing your story. Thank you. Stanley Atkins. We got 2 more folks, and so we'll be done. Mr. Atkins, glad to have you here.
Thank you, Chairman. Thank you for everybody having me. My name is Stanley Atkins II, and I'm a United States Navy veteran. I've served 2 deployments in the Persian Gulf. I turned to cannabis about 2.5 years ago. I was a full-time employed Clayton County firefighter paramedic. Just before resigning due to physical illness, I was nominated Paramedic of the Year for the Region 4. So I became ill with a gastrointestinal illness. I was fully employed at Emory University in the ER as an ER paramedic. I became ill. I lost about 55 pounds. Emory did every type of testing you could name, short of radiation, which is where I drew the line. I was able to gain access to some cannabis oil, and I've since been able to start the healing process. As far as what we're discussing today, safe access is paramount. I was arrested 30 days to the day post-deployment for cannabis possession. I've served 2 deployments, like I said. I think that for veterans, we've earned the right to medicate naturally for serving 2 deployments in the Persian Gulf. As far as the other entities we're speaking as additional resources, when we grow this program, I'm referred to as the Cannamedic, because I took cannabis and paramedic and I put it together. Because the problem that I've found is there is a direct disconnect in the correlation of information from the top down to the patient level. I have a unique ability to correlate complex information and the basic skills for lay person, and my ability to do this was molded by Clayton County. I've ran over 10,000 EMS calls in Clayton County, Georgia. I was also the paramedic that intubated this University of Tennessee student that fell from the Georgia Dome a few years ago. So for people to say that professionals can't use cannabis and intellectuals don't use cannabis, we are here to break the stigma. And as far as the conditions in which we've broached today, cannabis versus the opioid epidemic. As you can see, I'm wearing a hand brace. I wear it most days. I'm wearing a knee brace. I have bilateral osteoarthritis. My abdominal pain, I describe it as a fillet knife, not very wide but long, piercing through your liver, through your diaphragm, and into your gallbladder. And every time your heart beats, someone twists the knife. The human heart beats 60 to 100 times a minute. Now imagine that pain for 3 years straight. That pain and illness forced me to resign from Clayton County Fire Department, and by becoming a public cannabis advocate, that also entailed that I had to no longer practice emergency medicine. But I can say confidently that cannabis saved my life, especially through PTSD. I was commended for a multitude of 911 emergency calls, but no one checked on me after that 24-hour shift. Because yes, I can deal with a baby shot in the head, I can pull children out of a swimming pool, but no one checks on the EMS and the first responders when they're suffering. Most people turn to prescription narcotics because unfortunately in that demanding field, every time you go to Kaiser, you're gonna leave with Vicodin. I've eaten tens of thousands of prescription pills in the course of my life due to being an adrenaline junkie and not always sticking the landing. But now I have been opioid free for over 1 year, and I can say that cannabis saved my life. Especially, we lose 22 veterans a day, and those are the old figures. Those figures have increased with the increase of fentanyl usage by veterans. And since yesterday, today, and tomorrow, 22 veterans are going to take their life due to post-traumatic stress disorder. And I think that we need to broach that as a whole. And my final point is, Atlanta, Georgia has been deemed the HIV capital of the United States of America. That is embarrassing. As a healthcare provider, as an African American, and as a concerned citizen. Atlanta, Georgia is compared to Bangkok, Thailand, Rio de Janeiro, Brazil, and Durban, South Africa. 1 in 51 African Americans in Atlanta, Georgia have the HIV virus. HIV is preventable. 60% of HIV and AIDS patients admit to using cannabis to cope with the side effects and signs and symptoms of this debilitating disease. I reached out to an entity here in Atlanta, and they told me verbatim that cannabis does not help with HIV, and as long as they take the medications, it won't have any beneficial factors to the patient. Research studies, and you can Google this information, that aside from the physiological effects, the psychological effects of this autoimmune disease is depressing. No matter if you look in the mirror and you don't look sick anymore, these patients are still depressed. These patients are still suffering psychologically, and cannabis is paramount in helping these patients for mental health. If Atlanta, Georgia can be the HIV capital of North America, I would like to see it the cannabis HIV treatment capital of North America. And that is all.
Okay, Mr. Atkins, thank you. Any questions for you? Thank you for your testimony. Thank you very much. Okay, final, Bridget LaCourie? Bridget LaCourie? Yep, sorry. Yep, yeah, sorry. Help me how to pronounce that last name.
LaCourie.
LaCourie, okay. Glad to have you here. Why don't you share your
I'm going to try to keep this as short as possible. My name is Bridget LaCourie. Okay. I want to thank you all for letting me speak here today. I'm here to speak about 2 of my children. I am the mother to 5 children. All 5 of those children have various disabilities and illnesses. Autism, ADHD. My daughter has neurofibromatosis, which causes brain tumors, optic nerve tumors. My son has cerebral palsy and a rare autoimmune disorder known as chronic recurrent multifocal osteomyelitis. My life is an endless stream of doctor's appointments, IEP meetings, hospital stays. I suffer from post-traumatic stress disorder, anxiety, depression, all of those things. As a result of my life. My daughter underwent chemotherapy to treat an inoperable, non-cancerous brain tumor. She was on multiple medications, including Neurontin. She was max dose before the end of her treatment. Neurontin is a medication that's used to treat neuropathy, which causes nerve pain. It's burning. She's 7 years old. She was on Loratab, an opioid pain medication for migraines. She was on Periactin to help deal with the migraines and to stimulate her appetite because of the chemotherapy. She was on Zofran and Phenergan to help her not be nauseated and throw up. That was a lot of medications. My daughter did a 52-week treatment, 52 weeks of chemotherapy. She's 7, and it wasn't cancer. December 18th, 2015, my sister passed away from an opioid overdose. December 30th, my daughter went into anaphylactic shock from the chemotherapy that they gave her. She almost died. I watched helplessly as they gave her oxygen and an EpiPen and tried to bring her back from the result of the chemo. And we ended up spending the new year in the hospital. And as I sat there thinking about losing my sister to pills and watching my daughter take all these pills and then seeing this medicine almost kill her, I never really thought that going into chemotherapy she would not come out of it. That thought never crossed my mind. So I started wondering, there's got to be a better way, right? And I heard about cannabis oil, so I thought, well, why not? It has anti-tumoral properties. It can actually shrink tumors. It can It can stop the growth of the tumor, which was the whole goal of the chemotherapy to begin with. So I decided to get the THC oil. And 7 months into chemotherapy, we switched over to THC oil. Within a week, she was off all the pain medications. She was off the Neurontin. She was off all the anti-nausea medications. She was eating, and she was back to school full-time within 2 weeks of beginning the cannabis oil. My other son, Jackson, he was born with spastic cerebral palsy. By the age of 2, he was in so much pain he couldn't get off the floor. He couldn't move. We didn't know what was wrong with him. We spent many times in the doctor's office, in the hospitals for weeks trying to get an answer. We were told at one point that he may have leukemia. They finally did a bone aspiration, and they found out that he suffers from a rare autoimmune disorder, CRMO, or chronic recurrent multifocal osteomyelitis. And that's an autoimmune disorder that basically causes the body to attack itself. So he gets pain, he gets inflammation in his bones, he gets fevers, he gets joint pain, he has a difficult time even moving. He was prescribed a wheelchair and a walking aid at his worst. This disease causes bone tumors. And if it spreads into the spine, it then requires chemotherapy to treat. And the goal for that, or the reason that they do that is it's because these tumors break the bones from the inside out. So my son wouldn't be able to live a normal life. I decided to give my son cannabis oil as well. Day 1, he was off the floor. He was walking, he was rigid, he was stiff, he was struggling to do it, but he was doing it, he wasn't in pain. By day 6, he was moving completely fluidly like a normal 4-year-old child. He was pain-free. And since then, he's learned to run, he climbs stairs. He's gone back to his rheumatologist for the bone scans to check on the initial lesion that was in his sacrum. And they'd found that the bone lesion is missing, it's gone, they can't find it. All of my children's doctors are on board with what I'm doing, but they can't be. They cannot tell me that it's okay. They cannot give us a registration card. They cannot make it legal for us to do what we're doing, but we can't not do it. If we don't do it, my son doesn't walk, he's in pain. My daughter could possibly start chemotherapy. Again, my son could start chemotherapy. This is the only option that we have. As far as my autistic son, he's in New York. It got to be too much and I couldn't do it anymore, as Dale Jackson was saying. Sometimes you just gotta give up. So my son lives 800 miles away from me with his grandparents because there was no other option. And I'm just asking that maybe we consider allowing our doctors to make this decision for us instead of the lawmakers. Because they know us. They know what works. You know, his doctors are amazed at how well he's doing. But they can't, there's nothing they can do for us at this point.
Thank you for sharing your story, Ms. Lickery. I appreciate that.
Thank you.
And thank you for being here. And hopefully we'll provide some options here for you soon.
Thank you.
So thank you. Okay, members of the committee, I appreciate this. 5 o'clock. I know a lot of you have stayed here for the whole 2 hours, and so I thank you for that. Here's what we're going to do. We've got enough folks here to take action on the bill if that's the will of the committee. And so what I'd like to do is just have a very brief discussion of any questions that any of the members might have regarding the 4 changes that we're making to the existing law. Again, keep in mind there are 4 changes. We're adding 6 conditions, or with what's proposed in the law. We're adding 6 conditions. We're eliminating the end stage or severe qualification from 5 current conditions in the current law. We're removing the 1-year residency requirement, and we're removing the quarterly reporting. So I'm going to open the floor at this time if there are questions or debate about those 4 changes to the current law, or any proposals for or against, if there is any discussion on that. Representative Evans. Representative Evans, I would not be opposed to that change. We came up with that language after looking at what definitions of pain were done in other states, trying to walk the fine line of not being so broad that someone who really maybe didn't have a qualifying pain condition could easily get access. And so that was kind of the fine line we were walking. But why don't you, would you just read that language again, what you were proposing, and let's see if there's some other discussion about that. Sure. Well, just go ahead briefly so Matt can get it here too. Okay. Okay. I think we've got any legislative counsel. You're our legislative counselor today, Matt. So. All right. Well, why don't we've got that language written. And we won't take a motion for an amendment at this point. But let's continue to have some discussion about that. But I would not be opposed to that addition. So we'll open up just kind of any discussion on that particular suggestion or other thoughts. Let's see. Is Representative Clark or Representative Baskin? Yeah, Representative Baskin.
Thank you, Mr. Chairman. I'm concerned about at lines 45 through 48, if we were to eliminate the requirement for quarterly report, would there be any record anywhere with the state of the conditions for which people were taking cannabis oil in order to be able to judge the efficacy, as a report we had earlier this afternoon from the Bradfords, in order to determine whether patients taking of this oil is efficacious? We have to know who's taking what for what conditions and whether they're relatively better off than they were before they were taking this or when they were taking prescription medications. I understand that the burden on the physicians, this is something they weren't previously doing. It takes a lot of time. They're not paid to do that. Could we possibly come up with another alternative where the patients or the family members self-report?
That's a interesting proposition, and I understand the logic of wanting that. And I hadn't really considered the self-reporting mechanism. We had discussed maybe doing an annual report rather than a quarterly report to see if maybe that was, and I probably wouldn't be opposed to reducing it to an annual reporting by the physicians. I'm concerned that if the self-reporting was there, I'm not sure we'd achieve the objective we're looking for if it's by the patients. But
my concern, Mr. Chairman, is some of the reservations expressed by the two physicians in their obligations to report their quarterly report. It's not just the burden or the administrative burden of producing the report. It's asking physicians to do something physicians don't normally do, which is to report. This isn't really prescribing because it's not considered a medication. So normally a physician is reporting on medications that they're prescribing, and so it's not really something that they've traditionally done.
are you proposing then maybe
Just one point here, for example, in the Dr. Flamini email, he says, it is discordant that even though we are not dispensing or prescribing a product, we are asked to report clinical response and laboratory changes.
So your point, Representative Beskin, is just that we shouldn't put that burden on the physicians, but maybe put the burden on the individual patients, or responsibility maybe on the individual.
Right. I think societally we need to know who's taking what, but it's not something that really fits within the medical framework that we have.
What about this? If kind of take your idea of self-reporting. What if we tied some type of form to the registration when an individual patient renews for their registration card? If there was some reporting that they would have to provide at that point, in other words, I'm sorry? It's every 2 years. If you were a patient, potential patient, and you wanted to go register with the state, you would be required when you come up for your renewal after 2 years of having a registration card to provide some information. Maybe we could, that information would be created by the Composite Medical Board, which is who created the original reporting requirement. Something along those lines. Is that?
The patient to report their responses as well as they could. What were the dosages? How much did you take? What were your responses? Do you feel like it helped you? Did you comply? Did you respond? Were there side effects? I mean, I think all patients benefit from knowing that information, not just from themselves, but for everybody else who's.
Okay. And we take away that burden and responsibility, regulatory burden from the doctors and put it on the patient. And it would only, I'm asking, would that meet what you think you're trying to get to by saying, okay, every time you renew for the registration card, you would be required to provide that information? Okay. Any other thoughts from members of the committee on that idea? I think it may have some merit. We would need to kind of come up with some language if we want to. You want to noodle with that for a minute and maybe see if you've got an idea of learned attorney that you are, and while we have some further discussion about the bill. Yeah. Okay. Okay. Anybody else got other thoughts or ideas? I think both of those recommendations are. Katie? Representative Chairman Dipsey, are you 27? Yeah, okay, there you go. Yeah, they're not working, so you just have to speak loud, yeah.
So I was just going to wait after you said that to see if there was other discussion, but I just want us to be cautious. I know there's great urgency to do this, but these are two very important thoughts that did not come up in some of the other conversations and hard work that's already been put into this. If we need to come back and look at it, I don't want you or anyone here to feel, I know y'all all invest fun in it, I don't want you to feel that the rush to do it is more important than making sure we get it right.
Okay. And we're under no obligation to move on the bill today. And I don't want to make sure the committee knows that we're planning on meeting next Wednesday. So we could, if these are measures that we think are important enough to get legislative counsel to provide us some input, we'll be more. If it's a will of the committee, we'll wait till next week. So, any other thoughts or comments on legislation? Well, why don't we do this? As chair of the committee, I'll just make that decision. Here's what we're going to do. We're going to wait to take action. And Representative Beskin, can you help us? That way we won't put you in a rush mode here, and maybe you can work with you and I and come up with legislation, as well as Representative Evans. Representative Evans, if you'll help me maybe kind of take a little bit how we craft that language as well too. I think those are both valid points and worth considering. So, any other comments or thoughts for the committee? If not, we'll look forward to meeting together next Wednesday at the same time, and we are adjourned. Thank you.